Okay, thank you all for joining us at Shield, Illinois' December webinar, examining the effects of long COVID. I'm Alex Quigley. We're joined by our featured speaker, an expert for the evening, Dr. Gregory Tsaras, MD, MPH. She's a physician, epidemiologist, and infectious diseases consultant at SwedishAmerican Hospital in Rockford. Also, a clinical assistant professor and section chief of infectious diseases, Department of Medicine, and medical subspecialties at the University of Illinois College of Medicine in Rockford. Thank you for your time and effort on this presentation, Doctor.
Thanks for having me, Alex.
We'll get started with your presentation. If you have any questions, we'll be doing a Q&A session after the doctor's presentation. So feel free to type those into the Q&A box at any time, and we'll get those loaded up for afterwards. Whenever you're ready.
Okay. All right, we'll get started. We're going to be talking about the long-term effects of COVID-19, and we'll try and do this in 20 to 30 minutes so we can allow some questions that follow. I'll break down our lecture into 5 main parts: an overview of long COVID, we'll describe the clinical manifestations of long COVID, and we'll look at risk factors for patients who are at higher risk of getting this condition. We'll also look at what we know regarding management of long COVID, and also steps that we could take to prevent long COVID. Next slide, please. So just an overview of long COVID. This is a condition that has various names. Okay, one of the common names that people who have this condition call themselves long haulers, but there are other terms that are used both in the medical community and in the academic community. You may see terms like chronic COVID, long COVID syndrome, long haul COVID, post-acute sequelae of SARS-CoV-2 infection, post-COVID syndrome, and they're referring to the same condition. We all uniformly use the CDC definition, which is a wide range of new, returning, or ongoing health problems people can experience 4 or more weeks after first being infected with a virus that causes COVID-19. So simply put, the sequelae of COVID-19 that extend beyond 4 weeks after initial infection. That's well beyond the period of contagion or apparent clearance of the virus. Okay, so long COVID is basically an umbrella term for any and all lingering symptoms or health problems resulting from an infection by SARS-CoV-2. Now, to understand the extent of this problem or the burden of long COVID in our society, the incidence rate is about 10 to 30% for all patients who've had COVID in the past. Now, this is for those who have lab confirmed COVID-19. So we know that for everyone that tests positive for COVID-19, there's probably another person who never got tested, either because they chose not to or because they were asymptomatic. So for those that we know had lab confirmed COVID, about 10 to 30% of them were confirmed to have long COVID syndrome. The incidence tends to be a bit higher in patients who are severe symptoms that they have to actually come to the hospital for treatment. The incidence in that group sometimes exceeds 50%. So let's look at what we know about this. We know that currently there have been about 50 million or close to 50 million people in the US that have had lab confirmed COVID-19. So even if you go by the most conservative of estimates, we're looking at about 5 million people at a minimum who have been suffering from this condition, which we call long COVID. Worldwide, there will be more than 250 million people afflicted with COVID-19. And so at least 25 million, even by the most conservative estimates, will be suffering from long COVID syndrome. Scientists are still figuring out who gets COVID-19 and why they get that. All right, the symptom or symptom complex occurring in very unpredictable ways, and there are more questions than answers regarding this condition. So in our discussion today, we're going to discuss what we know so far regarding this condition. We're going to include what is considered biologically plausible cause of this condition, what we know so far from the scientific community that have been researching this condition, and our approach to management will be discussed as well. Next slide. All right, so the very first reports of long COVID was from a cohort of patients from Italy. We know initially that this pandemic started in China. Italy happened to be one of the first countries that were hit hard with COVID-19. So as early as July 2020, they had started gathering data on some of their patients who had symptoms of COVID-19, but who had residual symptoms or symptoms that had persisted for a while. So they studied these patients, and they wrote a research paper which was published in the Journal of American Medical Association, and gave us a first insight on this condition that was prevailing in patients who had experienced COVID-19. They described symptoms that were present during the acute phase, and in the majority of these patients, these symptoms persisted well beyond 4 weeks after they had been discharged from the hospital. One of the most common symptoms that were described is fatigue. And besides the Italian cohort, there have been many studies in many countries, including the UK and the US, where fatigue is one of the most consistently and frequently described symptoms. Over 50% of patients in most studies will have suffered with fatigue. And this is not unlike chronic fatigue syndrome, okay, following infections like influenza, infectious mononucleosis, and even previous incarnations of coronavirus infections. We had SARS epidemic, we had the Middle Eastern respiratory syndrome back in the 2000s, and patients who had this condition, who survived it, also had some form of chronic fatigue syndrome. So it wasn't exactly unexpected. Now, when we talk about fatigue as a long COVID symptom, we're not talking of just being overtired. Okay, these are patients who come and describe profound tiredness. They have unrelenting exhaustion, they have constant state of weariness, they have low energy and motivation. The classic presentation will be post-exertional malaise. So they do little chores and they're very tired. People who could walk down up several flights of stairs, go up 2 flights, and they're already worn out. This is a very classic presentation of long COVID. Shortness of breath or difficulty in breathing, which we refer to as dyspnea, is also one of the symptoms that might persist from the acute phase into the chronic or subacute phase, especially in patients who are hospitalized. And we'll discuss shortly why this occurs. Other symptoms of note will be cough and loss of taste or smell, which lingers for several weeks or months. It's not unusual to walk into people who've had COVID infections who tell you that they still haven't recovered their sense of smell. And it's been several weeks or months, and this is something that they've been dealing with. Now, despite the variety of symptoms that might present in long COVID, everybody's experience might be different. Okay, some patients may have short-lived symptoms that are mild. They might be just uncomfortable and inconvenient, whereas for others, it can be severe. It's prolonged and might cause a significant decline in the quality of life. Next slide, please. Right. So long COVID is basically a multi-organ disease or multi-organ syndrome. We know that the virus that causes COVID is a respiratory virus, and it primarily affects the respiratory system and the lungs. But other organs are involved in both acute COVID and long COVID. And the reason why this happens is that the virus gains entry into cells of the body via a receptor called the ACE2 receptor, angiotensin converting enzyme 2. Most organs in the body express this receptor on their cell surfaces. So the virus can have access to these receptors and can invade multiple organs or tissues in our body. And that is why you have symptoms that are widespread beyond the respiratory tract. We'll look at some of these symptoms, the ones that show more prominent signs and symptoms. But as we've shown on the graph or on the graphics, virtually every system is involved. Let's look at the nervous system, for example. How does COVID affect the brain and nerves? There have been numerous neuropsychiatric symptoms that have been described as part of the syndrome. We mentioned fatigue, which is usually due to chronic inflammation of the brain and neuromuscular junctions. Another neurological symptom is cognitive impairment. Okay, this is usually described as brain fog, and it has become one of the more concerning symptoms in patients with long COVID. Patients have difficulty with thinking or performing higher functions. They have difficulties performing their advanced activities of daily living, performing their hobbies, doing work. They have impaired attention, difficulty with concentration. They have some memory deficits, very forgetful of names, and they have a loss of their sense of time. Especially in our elderly patients, you have confusion, which we call delirium. They are disoriented. Some might complain of migraine-like headaches. Sleep difficulties are not uncommon. Patients have difficulty going to sleep or staying asleep. Besides these symptoms, there are quite a number of psychiatric symptoms that also occur in patients with long COVID. Okay, anxiety is quite prominent. Patients might have depression, which might vary from just mild mood changes to suicidal thoughts. Some patients might have OCD symptoms. And given the stress of intensive care, as many as 30% of hospitalized patients might end up with post-traumatic stress disorder. There are other more extreme neurological manifestations such as stroke and anoxic brain injury, but this is for those that are really, really critically ill. And so thankfully, those people are very few who have permanent neurologic deficits, problems with speech, language, focal weakness, and so forth. So that's the neurological or neuropsychiatric symptoms. We also have symptoms that are referable to the respiratory system. Okay, we mentioned that breathlessness occurs because it takes time for the lung function to recover after COVID-19. So when you measure patients' lung function after COVID, you do notice that they have some reduced diffusion capacity. They have inefficient transfer of gas from the lungs to the blood. If you do x-rays or CAT scans of the chest, you might see some imaging changes or abnormalities due to scarring of the lung tissue. They have decreased exercise capacity, and some of them, when you measure the oxygen, you realize that they are hypoxic, although they might not be showing frank symptoms. So respiratory system is particularly involved in long COVID for lots of patients, including those that are hospitalized. The other most important system is the cardiovascular system. Okay. Patients might present with chest pain, and it's due to inflammation of the cardiac muscle, or sometimes cardiac injury because the organs or the muscles of the heart have not received adequate blood supply, and they can leak troponin. So if you saw your physician with chest pain, based on the characteristics of the pain, they might evaluate you to find out if you had a bad heart attack or whether it was serious enough to require further workup. In the cardiovascular system, you also have problems with dizziness and palpitations. There's a condition that is quite common with long COVID. It's referred to as postural orthostatic tachycardia syndrome, or POTS. So basically, when you lie flat and you rise up quickly, you're supposed to maintain your vascular tone, maintain your blood pressure, and your heart rate is supposed to remain constant. And that's because your autonomic system regulates this process. For patients with long COVID, they have autonomic dysfunction. So what happens is that they become hypotensive and they become dizzy or have lightheadedness. Others might have just a subjective feeling of a fast pounding heart, which we call palpitations. And that's all one of the manifestations of long COVID. As you can see, there are many other organ systems that are involved. You have a GI system where you have loss of appetite, nausea, diarrhea, abdominal pain. The skin and hair is not spared. About 20% of people report hair loss. Few people might have a rash that persists for a long time. Musculoskeletal system, you have joint pain, muscle pain. Some people have problems with their kidneys, and they have a sudden inability to filter the toxic substances from their system. And some people might even have endocrine problems where they have newly developed diabetes, or they have inflammation of the thyroid gland, or some effects on their bone. So in a nutshell, this is basically a multi-system disease, a myriad of symptoms that are referable to several organ systems, both above and below the diaphragm. So let's go on to our next slide. So what are the possible causes of long COVID? Okay, to date, the exact mechanism is not entirely clear. There are so many hypotheses as to why this is happening. We already showed the prevalence or the widespread availability of the ACE receptors for the virus to latch onto. So that might be probably the most plausible biological explanation for why patients have long COVID. There's direct viral invasion of the tissues, and we know from our clinical practice that we've been able to isolate this virus from the lungs, from the heart, and from the gastrointestinal tract. It is possible that most of the other organs are also involved, because we know, again, from previous experiences with measles and other coronaviruses, that it is possible for these to occur. It is possible also that it's not just the live virus that is causing these symptoms, but any viral reservoir or lingering fragments, okay, or viral RNA or proteins can trigger this inflammatory response and lead to the symptoms that we observe. Anytime anyone experiences an infection, the way we deal with infection is to mount an immune reaction, and that might be either a local reaction or a systemic reaction to infection. And how well we deal with this infection depends on the balance between our pro-inflammatory response and our compensatory anti-inflammatory response. So if you have an over-exuberant inflammatory response to the virus, the so-called cytokine storm, and then you can have profound symptoms either acutely or persistently into the post-acute period. Some suggest that there is an autoimmune response. So your body makes antibodies against this virus that tends to attack these organs rather than a direct viral invasion into this tissue. We also know from our experience with patients in COVID in the hospitals that acute COVID-19 leads to what we call a hypercoagulable state. You're very prone to developing blood clots. And if you develop blood clots and you develop tissue damage to some of the blood vessels that supply the various organs, then they become, the blood supply to these organs become compromised, and they lead to some of the symptoms that we experience. Now, these are the direct effects of the virus. We also know that some of these symptoms might be due to prolonged hospitalization and intensive care in the hospital. There's a syndrome called post-intensive care syndrome, where patients have severe weakness after they've been in the intensive care unit and have been on a ventilator for a long period. It might be either due to the fact that they're not using their muscles and there's some atrophy sets in, or because we give them drugs to relax them whilst on the vent so that they don't fight the ventilator, so we can appropriately ventilate them. These muscles then get very weak, and it takes several weeks after recovery from COVID to get your strength back. And like I mentioned before, post-traumatic stress disorder may ensue because, again, being in an intensive care unit for a long time can be a very stressful condition. Now, besides the virus and the hospitalization, there might be some indirect effects that lead to these symptoms. And this might be what we call psychological distresses. Going through quarantine and isolation can have damaging effects on mental health and cognition, especially in the elderly patients. People are lonely, they have protracted social isolation, and these can exacerbate any underlying neuropsychiatric and behavioral problems. Okay, for our kids, school closures can affect them. For some of us whose work has been impacted by this pandemic, prolonged lockdown periods, these may have some traumatic effects on us. And even going through the trauma of seeing a family member sick or dying from COVID can have profound psychological effects on people. And this might be manifesting in the mental health symptoms that we are seeing, but also maybe manifesting in the physical, because we have something we call psychosomatic symptoms where you have psychological distresses but are manifesting in the physical. And most of our habits have changed. Okay, there are behavioral changes during this pandemic. Dietary habits have changed. People exercise less. People are apathetic to what is going on, and all these can affect physical and mental well-being. And it's not surprising that we see some symptoms that linger on for a while due to these psychological factors. Next slide, please. So we're going to look at some risk factors for long COVID. The bottom line is that long COVID can affect anyone infected with this virus, including those that are asymptomatic. There have been various studies that have confirmed this. Some groups of people may be more susceptible depending on a number of factors. So age is one of those risk factors. Contrary to what we observed in patients with acute COVID-19, where we have more elderly folk affected by acute COVID, we have younger people experiencing long COVID or long haul. The average age is about 40 years, with the 35 to 50 year group being the most common in most surveys or studies looking into COVID-19. Gender might play some role. Again, both men and women experience long haul to different degrees and extent, but surprisingly, there will be more women who have long haul syndrome than men. Acute COVID is the reverse. We tend to see more men with COVID-19, but we have more women with a long haul syndrome. In some studies, as high as 70 to 80% of patients are women with long COVID syndrome. Generally speaking, the more severe your acute illness, or if you're hospitalized because of COVID, your risk of developing long haul syndrome increases. And again, the number of symptoms that you have at the beginning of this illness might increase the risk of long COVID. So people with more than 5 symptoms have been shown in some studies to be more prone to develop long haul syndrome. Some existing medical conditions might also increase one's risk of developing long haul syndrome. Some specific conditions that have been found in studies include hypertension, obesity, asthma, and underlying psychiatric conditions. So patients who are immunocompromised, either from medical treatments that they receive or some autoimmune condition, have also been found to be prone to long COVID. Next slide, please. So I'm going to just give an overview of the management strategies for long COVID. There are 4 main pillars for managing long COVID. One of them will be a clinical assessment. Like I mentioned before, for some people, there is just mild, short-lived symptoms, might just be a nuisance, might be uncomfortable, and within a few weeks, their symptoms resolve. But for others, this can linger, it can be persistent, it can affect their quality of life, and we suggest that such individuals should be fully assessed, at least initially, by their primary care physician, because sometimes you need a holistic approach to tackling this long haul. You see your physician, you get a comprehensive history, you look at your symptoms, your comorbidities, any social and financial circumstances, because we have social workers available that can help you and make you aware of resources within the health system and within the community that might be helpful. Physical examination will be performed. You might get basic tests like checking your oxygen saturation, your heart rate. You might perform a 6-minute walk test to find out what your endurance level is like. And if it's indicated, you might get some lab tests. You can get blood tests done. You might get a chest X-ray and an EKG and so forth. So initial clinical assessment is important. If your symptoms are mild, self-management may be all that you need. Your primary care physician might suggest that you get a pulse oximeter where you can measure your oxygen saturation and your heart rate on a daily basis and give them feedback. We suggest that people maintain very healthy general health habits, well-balanced diet, make sure you're practicing good sleep hygiene, quit smoking, limit alcohol and caffeine intake. It's important to rest and get some good relaxation. Pace yourself and just gradually increase your exercise as you tolerate it, and make sure you set very reasonable and achievable targets. So these are some very conservative treatments that you can do if you're suffering from some of the minor symptoms of long COVID. The others that might need medical management, which will be done either by your primary care physician or in consultation with other specialists. So if you have some symptoms such as pain, you might be given some analgesics to help you. If you're having problem with sleeping, besides teaching you about methods to improve your sleep hygiene, there might be some medications that might help you in that circumstance. If you have any pre-existing condition like diabetes or hypertension, we'll make sure that it is well controlled. Those with specific complications, if you have a pulmonary embolism, you get a blood thinner. If you have a stroke, obviously you might be referred to see a specialist to help with that management. If you need mental health, there are resources and psychiatrists and psychological counseling that we can refer you to have. For those who have chronic dyspnea, they might need to go through pulmonary rehabilitation where they go through breathing exercises to help them recover their lung function. But it's important to know when to seek immediate help. All right, if you're having worsening shortness of breath, if you have unexplained chest pain, if you have new confusion, focal weakness, which might suggest stroke, you should definitely seek care immediately. The fourth most important pillar in management of long COVID will be social support. Okay, there are so many peer support or advocacy groups out there that you can join. There are community resources, there are faith-based groups that can help with this rehabilitation. We have special accommodations for children who suffer from long COVID that can be done at the school or even during their recreational activities to accommodate them, given that their tolerance to exercise and delays in focus and concentration might affect their schoolwork. Lastly, I'd like to mention that long COVID is recognized as a disability by the Americans with Disability Act, and because it is a physical or mental impairment that might limit or substantially limit one's major life activities. So there are some protections and accommodations that are afforded patients who suffer from long COVID. Regarding specific treatment, this is a question that comes up often. As of now, there are no proven treatments for long COVID. There's so many clinical trials that are taking place. There are people looking right now at hyperbaric oxygen, Montelukast, and some other medications for patients with respiratory symptoms. None of them yet has been proven to be effective. For people with chronic fatigue, breathing exercise are being looked at. 8-week exercise programs are being looked at. The studies also looking at high dose IV vitamin C, but we don't have any results from any of those studies. There are other dietary supplements that are being studied for patients with cognitive symptoms. Some would suggest probiotic supplements or some anti-inflammatory medications like tocilizumab, which we use for patients with acute COVID, is being studied also for long COVID. Monoclonal antibodies may or may not have a role that is also under study, and melatonin is also one of those. So there's quite a myriad of different interventions, both medication-wise and psychological therapy, cognitive therapy, and so forth. But we don't have the magic bullet yet for treating long COVID. Next slide. So how can we prevent the long-term effects of COVID-19? From what I just told you, the best way to prevent long COVID will be to decrease your risk of acute infection in the first place. How can we do that? It's just the time-honored principles that we've been applying throughout the pandemic. It's important that you get your COVID-19 vaccine, and if you're eligible for a booster, to do so as soon as you can. And I'll explain how vaccines are helpful in patients or decreasing the risk of COVID. First of all, you're getting a double insurance. If you're vaccinated, you have a 5 times lower risk of acquiring infection in the first place. There's also been a study that looks at breakthrough infections versus infections in patients who have never had a vaccine. And it appears that if you get a breakthrough infection, you are twice as unlikely to get long COVID compared to somebody who gets an infection in the absence of prior vaccination. So in theory, by getting vaccinated, you are basically decreasing your risk of long COVID about 10-fold, 5 times risk of infection and twice long COVID risk. We suggest patients wear a mask at all times to protect themselves and others, stay 6 feet apart from others who don't live with you, avoid crowds and poorly ventilated indoor spaces, and also wash your hands often with soap and water. And if it's not available, use an alcohol-based hand sanitizer. And these are all measures that help decrease acute COVID and therefore transition to long COVID. Next slide. So to summarize, there are millions of Americans and probably tens of millions globally who may be suffering from the debilitating effects of COVID-19 for months or years. Long COVID syndrome can affect anyone who is infected with SARS-CoV-2, whether you had symptoms, whether you had mild symptoms, or whether you were hospitalized. The science of long COVID is evolving. We're still studying who gets it and why. The causes may be multifactorial, and all organ systems are involved in this syndrome. We don't have any specific or definite treatments at this time, but there are various studies that are ongoing. And for now, the most important treatment will be prevention. Prevention is key to getting to stopping acute COVID and therefore decreasing the incidence of long COVID. So with that, I would open up for questions from the audience. Thank you.
Thank you very much, Dr. Tsaras. Lots of great information there. If you have any questions for the doctor, please feel free to drop them into the chat. We had a couple while you were speaking there. First, why does the loss of taste and smell happen with this virus? I don't recall ever hearing a virus do that to somebody before.
That's a good question. So just above your palate, there's a bone called the cribriform plate, and above that is what we call the olfactory bulb. Okay, so the part of your brain that is responsible for your sense of smell is in very close proximity to your nasal cavities. So the theory behind the loss of smell is that the virus probably invades this olfactory bulb, and that might be the reason why patients with COVID experience this sense or loss of sense of smell. In fact, that is the theory behind some of the other central nervous system long-term effects of COVID. The theory is that these viruses gain entry to the brain through the olfactory bulb, and then they get access to other parts of the brain and affect your cognition, your speech, language, and so forth. And others postulate that it might be getting through the bloodstream and getting to the brain and hitting the ACE receptors at that point. So again, the olfactory bulb is probably the reason why there's a loss of taste or smell when you have COVID-19.
Interesting, thank you. Has any impact of variants on long COVID, both in severity or affliction, been established?
That's a very, very good question, and I anticipated that. Now, most of the various studies on long COVID have basically been done in the last 1.5 years before we were hit with a Delta variant sometime in July and August. So most of the data is derived from probably the parent virus. We never really got too much of the Brazilian variant or the UK variant or the initial South African variant. So at this time, we haven't teased out whether the Delta variant will produce more long-term symptoms or whether this upcoming Omicron variant might produce higher incidence. But what we can say is that if the incidence of COVID-19 goes up, then there's going to be more people with acute COVID, and it stands to reason that there might be more people experiencing long COVID as a result.
Thank you. How many years must pass before doctors are confident that we know all of the possible side effects of long COVID?
Yeah, that's another good question. There's a lot of research that is going into studying long COVID syndrome. The National Institute of Health, the NIH, has put together research grants in excess of over $1 billion to study long COVID. There are over 100 centers in the United States who are being given small grants to study the effects of long COVID-19. So as mentioned before, we're not only looking at some of the treatments, we're also looking at some of the mechanisms by which this happened. We're going to be looking at patients who are going through this. There might be studies that are happening in an academic center near you where patients might come in and have blood samples taken. We might be studying some inflammatory markers to find out if there's something unique about the individual that is causing them to have prolonged symptoms. Even for those who happen to have long COVID who may end up passing on, they might perform some autopsy to find out if truly the virus has penetrated all of these tissues and, of course, the persistence of symptoms. So I think we're still early days into this. It took a very long time for us to understand some of the prolonged effects of measles, some of the prolonged effects of other viruses that cause chronic fatigue. And so I don't think that we are there yet, but hopefully in the next year or two, we might have some emerging data that might help find out what the causes and treatments are for this syndrome.
Thank you very much, Dr. Gregory Tsaras, for your information and your efforts today. For those of you who joined late, this will be going up in its entirety on our YouTube channel by tomorrow. Thank you all for attending. And again, thanks again to Dr. Tsaras. We hope you have a healthy and happy rest of your evening.